We are now about to start with our next session. I would like to request our chairpersons to please unmute and switch on the camera, starting with Dr. Mahipal Sachdev sir and Dr. Lahane Tayoro. And also I would like to request all the moderators to kindly take over from here, Dr. Mohan Rajan and Dr. Arun Sethi. Please, sir, over to you.
Thank you. Thank you very much and welcome to this particular national symposium. I don't see Dr. Arun Sethi, but welcome Dr. Lahane, who has really done yeoman service for the COVID fight in Maharashtra, being the head of the task force that is there. I have with me Dr. Mohan Rajan, who's again, I would say, who's really done yeoman service by providing ventilators, PPE kits every other day. We have seen him going and donating to the government hospitals and being there at the forefront of the COVID fight. Arun Sethi should join us also, and he has also been distributing these hand sanitizers, etc., in the community around Gurgaon. So we all know that when COVID struck us, it was really something that none of us had ever expected. It was like a tsunami. And I think we were fortunate enough to have the last major AIOS conference, I think, of any specialty that was done just before COVID. And then after that, I think we had the stamp released for IGO on the 60th anniversary of IGO at the Maharashtra governor's residence cum office in Mumbai. But after that, things really took us by storm, and all of us were really in a state of shock as to what has happened. There was a lockdown that was declared. We had to be within the house confines of the houses, couldn't meet our loved ones near and dear. And as we all know that human beings are social animals, I would say, and the morale kept going down, and the economics of the whole thing started to hit us. So I think we have the resilience by which we came back. The entire country is coming out of the second wave now, which is, but one doesn't need to lower one's guard, because a lot of people with the Delta variant and having another mutation in the Delta variant, people are expecting a third wave. So we have lost a lot of our members of the medical community, including ophthalmologists, and we need to stay safe because get vaccinated, I would say, because that would offer some amount of prevention. And we have to also assiduously bring back the ophthalmic practice that obviously got majorly dislocated. So we have great people with us who will be talking about various aspects, and I would request the first speaker, that is none other than Professor Lahane. I would say a great man and a great human being who has really contributed a lot in the community services. He's a Padma Shri awardee, and he's really worked very hard during this COVID times. So Dr. Lahane, Professor Lahane, please do give us an insight on what Maharashtra did, what the state of Maharashtra did in the COVID crisis, and how the country can also learn from this management from Maharashtra. Dr. Lahane, please.
Yes. Thank you, Mahipal, for this wonderful introduction. Mohan, thank you, everyone. Rajesh.
Sir, good evening, sir.
Ailan Kumaran, and the Sabaya Sachi, and all my friends here. See, today I am going to speak to you on my state, that is a Maharashtra COVID crisis. What did we do? As a Director of Medical Education, I was the nodal officer for the COVID. And you will see in the Maharashtra, the cases started, the number of the cases. It is better to find your courage to make a change when you can choose to, rather than being opposed to. If you do not make a change, change will make you. That is what Rai Bennett said. And you see, this is the Maharashtra battle I wrote in the guest editorial in All India Ophthalmic Journal. And the gravity of the situation, you will see here, the total cases in the world, total cases in India, when it was, and you can see the total cases in Maharashtra, it has now crossed 60 lakhs cases in Maharashtra. Total deaths are 1,19,000. mortality rate is 1.99. So that was the situation in Maharashtra. And see, why we were worried for that is Mumbai high population density. That is a 20,634 people per square kilometers. That is what the density of the Mumbai. And so we were very much worried for that. Now, what we did, how the strategies we started. The strategy we started is the infrastructure. That was the first thing that we created. Then the second thing, we went to the testing and tracking. That was very important. The departmental coordinations of our department, that may be a police department, that may be a revenue department, that may be a health department, that may be medical education department. All these departments were together. And then we started the isolation of the patients. Then we started the research. And then we started the vaccination because it came late. So that was the strategies we started. Now, identifying and converting occupied but constructed building into isolation center. What we did, we did both constructed building and also the centers, COVID centers. The super specialty buildings at medical colleges are converted into the COVID-19 dedicated hospitals were converted in the medical colleges. Every general ward bed was provided with the oxygen. Ventilators increased thrice than the March 2020. That we started. If you see here what we did, the total facilities which we made available in Maharashtra, it was just DCH, DCHC, CCH, and uncategorized was 6,749. These are the facilities. Number of the beds, you will see it is a non-ICU bed as 4,63,000. ICU beds was 32,000, and you can say the ventilators were 12,873. So that was the number of the ventilators we provided. If you see here, the state government has taken special efforts to step up dedicated COVID treatment facilities across the district. It is not in one district, but it is from the Mumbai to Gadchiroli. Special instructions have been issued to all institutional heads for identification and upgradation of the such facilities. And then you will see the establishing the separate COVID facilities in all GMCs. So it was a completely isolated area of all GMCs was made an COVID centers. Now, initial resistance was felt while involving private corporate hospitals, but later on, all these sectors has been involved. See, first time 3 months they were not with us, but later on, 80% of the private bed, that may be a ICU or that may be a normal beds, were mobilized for the COVID. State government has timely issued various guidelines and SOPs for smoother functionality and better coordination between the government and the private sector. So also we decided that how much they should charge. Laboratories, the government labs and the private labs. See, to begin with, there were only 3 labs in Maharashtra, 3 labs. And now we have got 102 government labs, 149 private lab, RT-PCR laboratories. And there are 255 laboratories, and where the capacity is more than 2,55,000 samples every day. So this what we did is in this you will see the samples tested till today as 4 crore samples are tested in Maharashtra. So before you can see the setting the VDRL lab was very difficult task. So why it was difficult task? Because see, the 19 department, Maharashtra department was not having such type of lab. The DMR has taken lead to establish 19 VDRL across the state with 2 months across the GMC. And the time taken to set up these labs and train the staff is a record itself. See, then there was a problem of the kits, the donations and CSRs. We got near about 250 crore CSR donation for all these N95 kits, medicines, ventilators, everything. And then the treatment protocol. So for this, what we did is a task force. Maharashtra was the first to establish the task force in the Maharashtra to guide the treatment plan. Now, novel concept of the novel virus. Now, collaboration, discussion, I will tell you, in all medical colleges, we took a VC, and that VC was monitoring each and every patient of Maharashtra, each and every patient that may be in any corner, and treatment was advised by the experts who were sitting in the VC. Every day we monitor each and every patient, and because of that, the death rate was reduced. Now see how it was reduced. We started in the April, and then you can see the death rate came. It was that time it was 38, and then the CFR and that came to 1.99. So reduction in the mortality by the task force, by the extensive the VCs and guidelines. The guidelines were same all over Maharashtra, and patients were monitored for each and everything in all over Maharashtra. See the trial and research. Apart from the prevention and treatment, what we did is the research. See, everything we did in the research mode. So the Favipiravir also in the research mode, Covaxin research mode, the Covishield vaccine in research mode, Sputnik vaccine in research mode. The project genome sequencing to detect. Now you might be knowing that the Delta was seen in the you can say Amravati. That was seen on 25th of the February, and that we diagnosed immediately because we were doing the genome sequencing. Now you are coming to know the Delta plus. So that Delta plus we found in the Ratnagiri, and that is because every month we are testing 3,600 samples. That is 100 per districts for the genome sequencing. So whenever you are opening the lockdown, that time what is important is you will have to watch the virus, and that watching of the virus is the genome sequencing, and that we are constantly doing everywhere. And that also particularly those patients are having the given the vaccine, but they are positive. Severe cases are there, or reinfection is there, or some there is a hotspot. So we are collecting, and then we are doing the genome sequencing. Now the coaxium, we are now in Maharashtra also we are going to produce the coaxium. Now this is what the government, Honorable CM sir, I think our CM was the really visionary. He has, because of him, I think we could do all these things, and I think he did the every support, and because of that, I think in Maharashtra, though thick populated, we could control both the waves. Real power. See, the what was the real power? With it was a postgraduate resident interns, and this is the second wave. When the second wave came, we were prepared. Yes, we were having the ICU beds, remdesivir, manpower. See, it was very difficult. We recruited the private doctors who were practicing, and near about 4,600 doctors joined, and they were working for 14 days in the month, and they helped us for every center. And then another, in April, there was a problem of the oxygen. So oxygen plants in the major public hospital that we made compulsory, and every public hospital that may government or private, now they will have to go with the oxygen plant. So we were prepared for that. The second issue, but still, Maharashtra record height single day was 68,000 cases. And because of that, another thing came in, that is a mucormycosis. And you see the COVID-19. So these two were fighting. And this mucormycosis also, like you can see like this, just you can laugh at this and look down. Maharashtra was one of the first state to call for the lockdown. So because the second wave was very, very steep. And so because of that, on 15th of the April, we came with the second wave for the lockdown. And that has reduced the case. Now, mucor in the wire, you can see also as I was telling, everything is in the research mode, and that helped us. Mucormycosis. Now, each and every hospital, we have got the mucormycosis ward in the ENT department, and we are treating combinedly. That is a ENT, dental, ophthalmology, neurosurgeon, everybody together, and physician. So we are treating these cases, and also the post-operative. Also, whenever we are discharging the patient, we are making the nasal endoscopy, and then we are discharging so that we can diagnose it early. When the patient is discharged, we are following the patient very closely so that we can diagnose this early. The Maharashtra leads in India COVID vaccination drive with more than 2.5 crore doses administered. The Maharashtra is first to have maximum number of the doses. It has gone to the 2.9 now. Now you can see this. The number, you can see the number of the Maharashtra is 2.86 lakhs people are vaccinated. Now here you see where we are today. See, we are at the 60,000 one day. And when it was at the 60,000, today we are at the 8,000. So this is what the Maharashtra did in this 2 months of time. So that was from the 14th of April to the now today is the 25th of this month. Now, are we resting now as the number is reduced? Future preparation. We want to go for the future preparation. 5 new government medical colleges, permission of the vaccine preparations, then the increase in the healthcare budget, the incentives and recognition and promotion to the doctors.
So, with all due respect, kindly wrap up in the next 30 seconds, sir, please. We are running short of time.
And this is the teamwork, and that we have finished the our can say. So now I think the with this I finish my presentation, and thank you very much.
Wonderful.
Thank you so much, sir.
Wonderful. Professor Lahane, I think exemplary work that has been done, proactive steps that have been taken, and taking everybody, like specifically what you showed also about the mucor ward, because it's a multidisciplinary approach, and that also is something which is great. Anyone has any comments on this? Any one of the panelists?
Yeah, I think that the work that they've done in Maharashtra should be a model, because with the third wave coming in, we need to be prepared. And most of the states are not aware how to handle it even now. They're pretty out of their depth. So this knowledge has to be shared in a very quick way. And also in terms of ophthalmology, what is the recommendation that Maharashtra has given? Are you allowing regular surgeries at the moment or not?
In Maharashtra now, from the you can say 15th of June, we have started the regular surgeries in Maharashtra. We are doing the cataract surgeries also, and all other surgery. We have started on 1st of June, but now from the 15th of June, the number is now surgery is increased, and the number of the cases are decreased. So in ophthalmology, I think there is no problem now, and we are doing. Only thing is that we are asking them that you should do the test, and after that only you should operate the case. That is what is the guideline.
Thank you, Dr. Lahane. We now go on to Dr. Mohan Rajan, and he'll be talking about, I think, Tamil Nadu. The second wave was the last state among the last state to get the second wave, but the numbers are now coming down. So let us see Mohan talk about the city of Chennai.
Thank you, Mahipal. In fact, Dr. Lahane's talk was an eye-opener for all of us, because Maharashtra preceded Tamil Nadu by about 4 weeks, especially in the second wave, and we learned a lot from Maharashtra, and whatever they have done, the groundwork, we were able to rectify that. I'm going to talk to you on what Chennai city we did in COVID crisis. Okay, what the government did social distancing, masks, vaccine, 20.15 lakh vaccinated, which is approximately 25% of the Chennai population. This is about figures about 2 weeks back, 2 days back. The government did testing, tracing, treatment, social distancing, masks and vaccine, all these the government did. And the government set up the testing, which is amazing work, which the government of Tamil Nadu did in Chennai as well. This is a golden triangle as far as the COVID-19 is concerned, whether you have the second wave, the first wave or the third wave, whatever it is, the testing, the treatment and the tracing of the contacts is very, very important. And this golden triangle, which we followed very, very meticulously. As you know, the lockdown activities were very meticulously followed by the previous government as well as by this government as well, during the first wave and now during the second wave, during the DMK regime. And the COVID testing has been done very vigorously, much more than I would say, any other state, I would say. And that's the reason why we were able to report more cases, because the testing was also more. So what we did as actually the first wave, the affected people were close to about 2.25 lakhs, recovered about 2.17 lakhs. And the mortality rate was 3951, which is from the February to almost 1 year of 2020. And the second wave, which is about only 6 months, we already seen a fatality of about 7953, and because more people were admitted during the second wave than the first wave, and definitely the mortality rate is definitely more during the second wave as well. So phase 1 March to October, the lockdown to 2020, the phase 2 March 2021 to till now, and we opened up just now with a couple of weeks, 1 week back, and it is now better. What we did as from the point of our hospital as well as the Rotary and the NGOs in Chennai. We did what is called the COVID slum relief project during the first wave. We did the project Oxygen or the O2 during the second wave, the COVID relief again during the second wave, and of course the vaccination drive, which we are doing on the vaccination on wheels, we are doing in the second wave as well now. So this is a COVID slum relief project wherein we distributed groceries to about 300 slum areas, about each slum area covering about 250 families, covering entirely about 775,000 families. The corona pandemic, as you know, brought millions of people in our country to slum, especially misery. And the CSR project was initiated by Rajan Aikar along with the Chennai Vision Charitable Trust, along with the Rotary, to provide relief to slum dwellers. Masks and sanitizer to Chennai City Police. Every section of the community we covered by means of the PPE kits, the masks, gloves, and doing this all done during the first wave, the last year, from April, May to about November, December, we did this, the COVID slum relief project. The goggles to the Chennai police, the food to the Metro Water people, the gloves to the Namakkal Hospital, N95 masks to the ICH and the AIOC2021 and many other government hospitals as well. And this is the part of the CSR initiative which we took, wherein we found out that it is very, very useful. At that time, during the first wave, the life was not a major issue. It is the livelihood. So the livelihood was taken care by means of giving the groceries, and not only the groceries, we also had rice, groceries, bread, milk, vegetables, medical checkup, eye checkup, medicines, masks, sanitizers, soaps, even sanitary napkins for the slum dwellers. And on an ongoing basis, on long-term sustainable basis, which sustained them through the entire pandemic, entire lockdown period for almost 4 to 6 months during this period, for about 300 slum areas, covering about 250 slums, 250 families in each slum, covering the entire this thing, about 75,000 families, which is phenomenal. And the vaccination drive, we also started in Rajan Aikar in the year, this year only. We vaccinated more than almost 3,000 people till now during vaccination. And of course, the second wave was slightly different from the first wave. The second wave, it was the life which was more than the livelihood. Of course, the livelihood, people got used to it, the livelihood, but the life was at stake because of lack of beds. If the beds are available, the oxygen was not available, the oxygen was available, the drugs were not available, and the drugs are available, the ventilator was not available, the ICU was not available, and that because all overflowing, it was all going to the brim. So that is the reason why we started the project O2, again a joint project of the Rotary and the Rajan Aikar, wherein we distributed oxygen cylinders, oxygen concentrators, oxygen flow meters, and oxygen generators. We, in association with the L&T and other corporates, and we made sure that the oxygen cylinders, all these are available to the government hospitals. Apart from that, we also gave the drugs like heparin, IV methylprednisolone, mouthwashes, plastic sheets and bags for the dead bodies, maintaining the dignity of the thing. These are the things we did in the Project O2 or the Project Oxygen, wherein we had donated oxygen cylinders, oxygen flow meters, oxygen concentrators, glucometers and glucose strips, low molecular weight heparin, and antiviral drugs, ECG machines and rolls, plastic sheets and bags for the dead and the deceased, maintaining the dignity and identify for the disease as well. ECG machines, oxygen flow meters to the government hospitals. There are about 4 or 5 government hospitals in Chennai, which we covered, like the Omandarur Hospital, the government general hospital, or the Rajiv Gandhi General Hospital, the Kilpauk Medical College Hospital, the Stanley Hospital, and various other smaller institutes as well, and also the primary health centers in and around Chennai also be covered by means of this oxygen concentration, oxygen cylinders, which was very, very necessary during the second wave. The second wave, the problem was the oxygen, getting the beds and creating extra thing, as Lahane sir beautifully mentioned, how we created extra space in the ICU, how we created ventilators and thing. So this is the project which helped Tamil Nadu breathe and Chennai breathe during the second wave as well. And the oxygen concentrators, again, to various hospitals, plastic sheets and plastic bags for the deceased, for the maintaining the dignity. So it's very, very important, because these plastic sheets and bags for the dead bodies which were taken to the crematorium. and again ECG machines and rolls, oxygen flow meters, N95 masks, oxygen cylinders to Stanley Hospital, glucometers to Omandarur Hospital, low molecular weight heparin drugs to the COVID patients in Stanley Hospital and other hospitals, government hospitals as well, IV methylprednisolone, heparin, candid mouthwash to prevent mucormycosis, oxygen concentrators again, and flow meters to primary health centers, donation of ventilators to government hospitals and government hospital, which again is necessary because as part of the ICU setup to maintain the critically ill patient. Again, during the second wave, as part of the Rotary, we took up a very ambitious project called the Cove Relief Project. In the Cove Relief Project, what we did was we gave 1,000 rupees worth of groceries for 30,000 people, which is a total amount of about 3 crore we spent on this bag worth 1,000 rupees, which contained all the groceries for almost 2 to 3 weeks for them, and distributed 30,000 bags, and which is initiated by the Health Minister of Tamil Nadu, and this is the Health Minister of Tamil Nadu along with that COVID Relief Project. Again, I'm in the mucormycosis panel as well. Lahane sir has beautifully mentioned, and this is something which you have taken up as a major initiative. That is, prevention is better than cure, as mucormycosis is very important. This morning also I had a meeting with the Chief Minister of Tamil Nadu, and wherein we created public awareness, post-COVID patients, immunosuppressed patients, personal hygiene, oral hygiene, early signs to sing, and also betadine gargle, blood sugar at the time of discharge, home monitoring of the patients post-COVID, which we are doing along with the fever monitoring as well. Again, patients with low socioeconomic status we are trying to target. This is a mucormycosis chart, which is seeing in signs and symptoms. We produced these leaflets and pamphlets and posters. Posters are fixed up in various hospitals, government hospitals as well. The leaflets are given along with the patient's discharge summary, so that they will know the early symptoms and signs of mucormycosis and consult a doctor immediately. And again, Lahane sir beautifully mentioned a nasal endoscopy at the time of discharge, and now and then training all the ENT specialists. It's a multidisciplinary approach which is very, very necessary. Again, these are the patients who mucormycosis till the date affected, 787, cured 43, death about 68. And these are the entire 360-degree activity we have done as part of the COVID relief, the COVID slum relief project, giving groceries, the project O2, the COVID relief project, the plastic bags for the death and the disease, masks, sanitizer, PPE kits, goggles, face shields, gloves for all the healthcare workers, all the people, drugs for the COVID patients, vaccination, COVID shield for patients in the age group of between 45 and above, and mucormycosis awareness also we have created. Thank you very much, wonderful for the wonderful opportunity and the patient attention as well.
Thank you very much, Dr. Mohan Rajan. Excellent work done. Again, shows the compassion that you have, and being. I've always seen you as somebody who's working 24/7, a very active individual, and a great human being at that. So I think great initiatives that you have done to alleviate the hardships and miseries of people. Dr. Lahane, you want to say something?
Yes.
Thank you, Mohan. It was a wonderful work, and I'm very happy that the Mohan Rajan was instrumental in doing everything. It's very useful. I will tell you, very useful. And I really congratulate you for doing such work when it was a need of the hour. Thank you.
Absolutely. Thank you, sir. Thank you, sir. Coming from you, it's a great honor for me, sir.
I think we can use some of these ideas as ophthalmologists on the AIOC platform to do it at a bigger scale with the third wave, if and when it comes, so that all the ophthalmologists can learn from your experience and do it. So our next speaker is Dr. Mahipal Sachdev, who needs no introduction, the outgoing president of the AIOC and a very dynamic ophthalmologist. And he'll be talking to us now about staying financially afloat in COVID crisis now and beyond. Dr. Mahipal Sachdev.
Thank you, Arun, for the kind words. I'll be talking about the economic disastrous impact that has happened across the world. But one thing that is happening is that there is a rebound that is there, but one needs to plan as to how the things are. As Mohan was also saying, people are getting used to what I will say the new normal, you have alpha, beta, gamma, and now you have delta, and now from delta onwards you have the mutation that is going on. The impact has been rather very severe. The second wave was obviously, as said, much higher. And what has happened is that it comes in waves, and you can see that the second wave coming here as compared to the first wave, the numbers actually shot up, and there was in lot many states, you had problems right from the diagnosis, the treatment, and what Mohan also said, unfortunately, loss of dignity even in death, where we had the horrific scenes of bodies floating in the rivers. So unfortunately, we were less prepared, and this is something that we hope and pray that we don't have to go through again. And we should be better prepared, and we should stay safe as it is. There are several colleagues who have lost their life, and that is something very, very unfortunate. Now, when you look at healthcare, there you can divide it into two parts. In one, when you have the COVID, where we don't actually come into the thing except maybe for mucormycosis, but the wards, etc., where you wanted COVID beds were overflowing. But when you look at the rest of the care, it really tanked because there was apprehension of people going to hospitals, and there was apprehension that we might contact the disease. Now, one of the main factors within ophthalmology is that a lot of our surgeries, if not all, obviously not all, but majority of our surgeries are elective surgeries, and that really was a problem. Now, the impact in the disruption of the healthcare was also on the supply chain. As you could see that there was the problem of the APIs, etc., for pharma products coming in, the demand suddenly going on, and the demand was at least raised by 1.5 times, if not more. That was of the ventilators, etc. Now, the problem that came in was that one had to redouble the efforts in quick time, and that is what was required. That strategic alliances, even car manufacturers came in to have some sort of ventilators or some push mechanism for the air. You could see people having the industrial oxygen being sent over for use. That was there. And this is, unfortunately, this was across all national television, that there were news within Delhi capital region that we have oxygen for 10 minutes more, etc., etc. Supply chain management was bad. There were some states which had more industrial oxygen. That was not being done. There was internecine war between the center and the state, and this lack of coordination between the stakeholders worsened the whole thing, and the gap in the healthcare came forward. Unfortunately, we as healthcare professionals have always been saying that in India, the percentage of GDP spent on healthcare is very, very poor, but it has been of no effect to the government. I think now at least they should focus on spending more money on healthcare, because a healthy nation gives the maximum impetus to economic growth. Now, let us see as to possibly the second wave, the numbers coming down. First wave went through, and the second wave numbers, what next? So what all do we need to assess to innovate and to sustain our practices? Because there has been a couple of practices that have gone down under. There has been sustenance problem, number of people, unemployment rate has really gone up across the world. So what actually was a transformational change that I will say, which has happened with great rapidity. Otherwise, it might have taken 5 years. But I think this is one good step that the government took, was to legalize telemedicine. And the new hospital became digital on a smartphone. So teleconsultation actually went up, it boomed. There were people who were doing teleconsult, especially the pulmonologists, the internal medicine people, right from morning till the midnight. And a lot of the treatment for COVID, because there was a normal advisory that until, of course, there are several signs which would require you to get hospitalized, otherwise you should be within home. So this teleconsultation became important. Home care with people going with PPE, that became also something which is very, very important. We as ophthalmologists, I was just in the previous session attending Think Under the Apple Tree. There were several innovations that came to make home care to home diagnosis, checking pressures, within the home, doing a slit lamp photography, doing bundle photographs, etc. that came along. E-pharmacy, you can see all the companies, right from Reliance to Tata's to everybody wanting to get into e-pharma, which is there, and the awareness tools have actually gone up. Artificial intelligence is being talked about. So I think what we have to re-engineer is to reduce the rush into our practices. Even if COVID goes away, which it will obviously, we should try to reduce the time of the patient there. So appointment systems need to be good. You need to reduce multiple visits. If the same thing can be done over a teleconsult, I think we need to look at that. The patient journey time needs to be reduced significantly. Now, there is a company called Pi in China, which does everything on a teleconsult, from history taking, demographics, address, etc. So when a person actually reaches a particular place, and then you could also have a digital refraction that has been done at home, or a digital vision check that has been done. So when a patient comes to your hospital, the time that the patient is within the hospital is actually reduced to less than half. So that is something which is going to happen. COVID safety protocols need to be followed, staff training for multitasking, so that you can increase the span of the hospital working, so that there isn't too much of rush at a particular time. Digital marketing, and above all, the artificial intelligence, that is something which is going to be there. Now, whenever you are in a situation where economy is bad, you have to look at saving the cost, and what as AIOS levels also we did, and what you have to do is maybe form better B2B things where you can get consumables at a lower price. Force majeure was there, and also rents. Those people who have rented premises, the rents are being renegotiated. At least in a couple of places, there has been a rent reduction. Electricity saving, go green is something very, very important. AMCs, you have to look what is there. Look at the credit period. You could actually look at your loans which are there and have them re-engineered for you with lower interest rates, because the interest rates have gone down significantly. And since the patients are not coming, I think spending a lot on the marketing cost does not make any particular sense at this particular point. So what is very, very important is that you have to rethink. You have to actually reimagine as to how you can reduce the patient time, you can reduce the journey, how you can reduce the cost. It is, according to me, difficult to increase the per patient procedure that is there, that you are wanting to do, because this is something very, very difficult for a patient to pay up at this particular time. So what I will say is that this is the slide that we got from McKinsey. First is resolve. That means address the immediate challenges that COVID-19 represents to the institution's workforce. You have to keep them safe. The customers have to be kept safe, and the business partners have to be kept safe. The second R is resilience, and that is the addressing the near-term cash management challenges, the cash flow, and broader resilience issues during the virus-related shutdown and economic knock-on effects. So once you have resolved, you have done this resilience, and then you need to return back to ophthalmic practice. You need to create a detailed plan to return to the business back to the scale quickly. That is something very, very important. And all of us got a reasonably very good scale in the months of January, February, and March when the COVID struck back again. Then you have to reimagine your business as to what is going to be the next normal, whether there is the help of the digital media which is there, how do you reduce the time, what a discontinuous shift looks like, and the implications for how the institution should reinvent itself. I think it is something very, very important that we have to do. And finally, we have to reform ourselves so that we remain meaningful, we remain useful, and our institution stays afloat, and we are able to grow and bring in new technology. So we need to be clear about how the regulatory and the competitive environment in the industry may shift. And I'm sure there is going to be a rapid shift in the environment of healthcare delivery. Healthcare expectations are going to be different, but we need to actually look and reform ourselves to be able to maintain ourselves because of this COVID crisis. So that is what I have to say. Thank you very much for your kind attention and presence.
Fantastic talk, Mahipal. Mahipal, very I just want to add one point, Mahipal. I think it's important for all of us to do an introspection and find out what are our strengths and weaknesses, so that we can cut down the cost as well. And the 5 hours, I really like the 5 hours at the end of the talk. It was very good.
So Mohan, Dr. Lahane, maybe you could continue with the next speaker. I just have to go to another session and I'll come back. I think the next speaker is Rajesh, who will be talking about what COVID has done to the residency program training.
I invite Dr. Rajesh, and he will speak on the postgraduate training in the COVID era. Dr. Rajesh.
Thank you, sir. Thank you. Thanks a lot. It's a matter of great honor that, I'm sharing the dais with people like Dr. Lahane and Dr. Mohan Rajan, who have done so much during this COVID era. I must say, Dr. Mohan Rajan, you are like Sonu Sood of Chennai. And I was not aware what all you have done. And
nothing when compared to Lahane, sir. He has done for the state.
No. Both Dr. Lahane, sir, and you, both of you have done so much that, it's really, that's why I said that it's a matter of great honor sharing dais with you people. I'll be talking about postgraduate training in COVID era. Now, before COVID era, we had a normal life, you can say, a normal teaching system wherein we had a physical classroom teaching, wherein, all the students used to sit. We had a proper, didactic lectures, and there was, face-to-face interaction, and that could increase the understanding of the subject. Then again, regarding clinical exposure, patients were there. A lot of patients were there in the OPD. A lot of patients were there in the ward, and bedside teaching was done very nicely. And bedside teaching is the best thing for a clinician. And that was really, that was something which was very useful for the residents. Then, of course, the surgical training, the more you do, the more you learn. And the more you teach, the more you learn as well. But as far as residents are concerned, over the last 1.5 years, things have not been the same. Earlier, there were so many cases, and by doing cases and by getting assisted by their senior, senior colleagues, it was a great learning experience for them. And even for theses and projects, which they were doing, there were enough cases to fulfill the mandate. But as COVID-19 came, as this pandemic came, everything got stuck. Everything got affected. Like for theoretical knowledge, initially there was a lockdown, so there was no class, there was nothing. People were in a state of shock. They just could not think of anything. There was no face-to-face interaction, and a lot of teaching in terms of lectures got affected. There were no patients. The hospital was mostly used for COVID. So there was no patient coming for ophthalmic checkup. Patients were, all in-house. Nobody was moving out. No bedside teaching was done. No skill transfer. No patient being operated. So the surgeons, the residents were not getting any training. And the thesis project also got completely shut down. There was negligible meeting as far as ethics clearance is concerned. No ethics clearance. Then whatever data was there, they were not getting the data. So even the thesis projects, these all things got affected very badly with impact of COVID-19. And then the biggest problem was this, that in a multi-specialty hospital, what happened, like something like ours, what happened that about 70 to 80% of residents and the faculty were posted in the COVID wards. So ophthalmologists leaving all the ophthalmic work and working in the COVID ward, trying to learn from the physicians how to handle, trying to learn from the anesthetists, from intensivists, how to handle these patients, what to explain to their relatives. And so this was all affecting very badly as far as the ophthalmic training is concerned. And even at that time, there was a decision in some states by the government to extend the residency period, but that was also to take up the COVID duty. So these all things were affecting the not only the training of the residents, but it was affecting them very badly in terms of their mental health as well. So a lot of new things came up. We all know that, with time and with problems, we try to innovate new things. We try to get back to new things. And then virtual platforms came in. So there are certain queries. I was just, when I was given this topic, I just spoke to a couple of my residents that can you just message me a few queries that you think during this period? Because we are having this online training, we are having this, all these things. So what are the queries in your mind? So these are some of the queries that they gave, that can virtual platforms replace the physical mode of theoretical and clinical knowledge transfer? Well, I guess no, they cannot replace. But yes, they can be of some help now and in future. Does wet lab give a real-time experience? Like we keep telling our residents that you should go to wet lab, you should try to learn in wet lab. But they said that does wet lab give a real-time experience operating on a patient? Our ophthalmologists who are getting the degree in this period are confident enough in clinical knowledge and confident to do surgeries in patients? And how to fill the gap of learning curve? Does more time suffice? When will we return to pre-COVID training, which I guess nobody knows? And are our young ophthalmologists trained enough to treat patients? And all these queries, part of which we can answer, but part of which is still not answerable. So what should we do now? Well, we have to develop online teaching to minimize disruption to student learning, and that is what we are doing. The virtual platforms are there to tell them what exactly is ophthalmology, to give them the theoretical knowledge, to give them the knowledge about patients. And there are so many webinars in this direction, and you can see the residents attending the webinars. Most of our residents, they keep telling that, yes, I attended that webinar, I attended that, because our own classroom teaching has got affected. Plus, in addition to that, apart from the webinars, we are also doing our online classes of our own group of residents. Like the center is divided into different units, so we are having the online classes. So on virtual platform, we are doing it. Then you can also show the videos of clinical methods, that how to examine the patient. One can create videos of slit lamp biomicroscopy, one can create videos of indirect ophthalmoscopy, etc., 90D examination, etc., and show to the residents virtually. You can take videos, unedited videos, and then show to them that at what step, how to control, if you are doing a rhexis, if it's running out, how you have to control it. So these things can be done. And of course, the residents these days are well versed with the online system, so they can catch up quite fast. Then the other thing is that you can have a recording of that, so they can attend at any comfortable time. So there's nothing that they have to be there all the time. Then there is another advantage that, there are faculty from across the globe who are taking classes, and then it also allows more and more members to join in, to participate. As far as skill transfer is concerned, as I was mentioning, we can do teaching on unedited videos, which we are doing these days. We are asking for unedited videos of current residents or even the past residents, or some of our own unedited videos wherein we have landed in trouble. So we can train them that these are the things that at this stage you have to control things so that you can learn. Then on go-tie, initially there was a problem in getting the go-tie when there was a lockdown and there was a fear of transmission, but later on we started getting go-tie. So on go-tie, every hospital can make wet lab. Wet lab can be established in every hospital. You just need a small room with a microscope, which may not be a very high quality, but it should have a video connection so that the trainer, the person who is training, who can see that what mistake the resident is doing. And then you can have a go tie and a stand to put on it And then, of course, machine, whatever you want to train, like FICO machine or SICS thing or whatever you want to train. Then simulators are a bit costly, but simulators are quite effective in training the residents because it improves the hand-eye coordination. And that is what is needed very much in microsurgery like ophthalmic surgery. Then it is always better to involve residents in teleconsultation, because in teleconsultation, the patient will tell about their symptoms. So it will be like an OPD. You're sitting in the OPD. You may not be able to examine thoroughly the patient, but you can have an idea of the differential diagnosis, that with these symptoms, what all are the possibilities. And then, of course, the senior person's role comes, that he can give you an idea that with this we can, reduce down to, these many differential diagnoses. And this is, the surgical simulator that we have, and this is how it looks like. So when the residents, they do, say, suppose one is practicing rhexis, so at times it shows, suppose the hand is not moving properly, it shows how the rhexis is extending. So how you have to control it. So it gives you a good hand-eye coordination, and that is very much essential in a microsurgery like ophthalmic surgery. Goat eye is something, as I said, that you can, a lot of surgeries can be practiced on goat eye, and it may not replace a real patient, that is very true, which was one of the queries of our residents, but it can be of great use, because if somebody learns to do rhexis on goat eye, he will be very easily doing rhexis in human eye. This is based on my own experience, I can say, because doing rhexis in a goat eye is more difficult than doing rhexis in a human eye when one is practicing. So this is something which one can practice and one can learn. So in every hospital, such a facility can be installed with a very minimum cost. This is what graph of a goat's eye, wherein the residents can practice. You can do a keratoplasty as well, put sutures, so hand-eye coordination can be done. So this is what is the new normal. You can later on use this teleophthalmology and the other things also as a part of follow-up of the patients. And the only thing I would like to add is that we will definitely get back to our new normal, but then these are the situations which teach us, and in future also we can use the virtual platform as well as teleconsultation as a part of training the residents. And regarding thesis topic, currently we should give topics related to retrospective analysis of data and small sample topics, etc., so that it can be completed fully. So we have to think out of the box in this situation. We have to plan as per the situation, and where there's a will, there is a way. We have to find out ways to train our residents. Thank you very much for your patient listening.
Really a fantastic talk, Rajesh. What I want to say is my sympathies to the postgraduates who are in this COVID era, seriously, because everything else they can learn. They can learn the theory classes because online classes are there.
Absolutely.
So many webinars are there, beautiful webinars are there. AIOC itself is conducting so many webinars. They're able to learn everything else. But for surgery, they need to do. So we need to either go to the goat eye, or probably simulators are the one of the way, but it's very costly.
Yeah.
The problem is very difficult to implement it in all the centers. Laghane sir, I want your opinion on this, sir.
I think what you are saying is very true, because for the residency, not only the ophthalmology, orthopedic surgery, then the gynecology, this plastic surgery, neurosurgery, then the cardiac surgery, everywhere I will tell you, there is a very, very big gap of 15 months. And those batches who were in the second year, I think they have not done it. The first year, they have not done anything. They have joined 15 months before. But till date, they are only in the, because they are junior and posted in the COVID ward. So that is the problem. So now what I'm telling, I have issued a circular to all the teachers that from the 15th of June, that the cases may be less, but all the cases should be used to teach all these people who are now going in the third year. And so the extensive teaching by the teachers, and I have also asked not only the SRs, but also the lecturers, assistant professors, associate professor, and professor, they should teach and submit with the report that what they are taught practically. I don't want much theory because they all are tired of theory. Every day they are listening. So I want them practically what they have taught to them, not only the goat's eye. You can use goat's eye, yes, for the experience, but on the human eye, and they should now feel of the patient, how they can treat the patient. And we
Yes.
are basically admitting mature cataract to teach them in not only in my hospital but all over Maharashtra. We are admitting the patients who are operated in the other eye so that other eye can be operated. They we will permit them. So that we are doing it not in one subject, all subject in Maharashtra, and we will make them feel that we have trained them properly in Maharashtra.
This is a wonderful idea, sir, that we should focus right now on the third year students more, so that, because they will be passing out very soon. So we should focus whatever patients we get, we should focus on the third year students.
Yeah, another big problem, Rajesh and Laghane sir, is that because we all depend on the eye camps for getting the patients for the postgraduates for the training, and the eye camps, there are a lot of protocols now. We are not able to conduct eye camps. I'm talking about in state of Tamil Nadu. I'm not sure what is happening in Maharashtra, but
Everywhere.
but I'm just telling you, eye camps is a big problem because even if we have eye camps, you can have only 50 or 100 people in that camp. We can't screen more people, and that is the reason why our workload, everything, even if you after the lockdown is lifted, also the same problem is there. So we have to overcome this.
I will come. I will tell you.
Yes, sir.
What we did in Maharashtra, because see, we can't gather the gathering. So what we have done, we have got the ophthalmic officer, that is ophthalmic assistant, and that is under the national program. We have got 685 people working in Maharashtra. So we asked them to go to the house survey, and after survey, diagnose the patient of cataract, diagnose patient of some diabetes or some problem, anything. But cataract we are diagnosing, and we are bringing the cases in the, you can say, the at big places in the bus. So in the bus we are bringing, only thing is that we are not bringing much relatives there. So in one bus we are bringing near about 30 patients. That is a 45 seater. We are bringing 30 patients and operating. But here no gathering. In the wards also, one cot is not in one cot there is no patient, other cot there is patient. Otherwise there is a distance of 2.5 foot we are keeping. So that is helping us, and that we are doing routinely now, not only on Saturday, Sunday, but also we are doing on the 2 or 3 days a week.
Very good, sir.
So I have a little suggestion to give. They say every pandemic has an opportunity. Don't you think the time has come to consider 3 things? Number one, that we should have a national level exam when people are paying for professional exam, so that the standard remains the same. We should have something like a need to pass out of MBBS, a need to pass out of first profession. Secondly, with Zoom available so freely, why can't we have national lectures so that students studying in remote medical colleges, where the teaching may not be up to the mark, could access the talent from Bombay, from All India Institute, from PGI Chandigarh. So if they could give 2 hours every day for every specialty, so you can have across the board national talent. So, somebody like Dr. Lahane or Dr. Rajesh Sinha could address on a particular topic. Now, LVP does this for their own hospital. All India Institute does it for its own training, but they're all silos. If it comes at a national level, look at the dramatic change it will make in academic exchange. The third thing is, in terms of surgery, it has always fascinated me that in India we need eye cam surgeries to learn surgery. But some of the smartest surgeons still in the world come from the United States, where there are no eye cams. Now, how did a gimbal discover capsulorhexis? How did a Harvard Fine discover the steps of phaco? These people do not have poor man's eyes to that extent. They have veterans hospitals. But how is it with limited number of surgeries they're able to excel? So that is something which we have to realize, that mass surgery does not mean quality surgery.
I think what Dr. Sethi was telling is very true. That what we have done is, I know we are doing out the video conferencing, and what we have done is we have made a lectures, not all over, but we have made out of 19 medical colleges of government of Maharashtra. Up till now, we have covered 12 medical colleges where we have got the virtual lecture halls. They are sitting there. They can ask the question in the real time, and we can discuss this. That we have started. And we have made a PHM department of the government of Maharashtra, that is JJ Hospital, is a virtual classroom. And I will tell you, this virtual classroom is a very good classroom where we can teach the people outside, and they are sitting in the lecture hall. So that we have started in 4 medical colleges. Now we are doing it, but it is also helped by the government of India. It is the scheme of the government of India under the, I think, elderly people. So from that they have given us the money and we are doing it.
Okay, sir. I think we're running short of time. We'll go to the next topic. And we
So
have Vilan
Sir,
Kumar.
if you allow, I have to attend another session.
No problem, Rajesh. Thanks a lot, Rajesh.
Thank
Nice.
you. Thank you.
Vilan Kumaran is a very, very dynamic, prolific surgeon from Bangalore, and he's going to talk to us on a very important topic: my single practice in COVID crisis. Vilan, all yours.
Thank you, sir. At the outset, I would like to thank Dr. Mahipal, sir, and the scientific committee and Dr. Partha Biswas, sir, for giving me this opportunity to represent to talk about what happened during COVID crisis among the doyens. Dr. Lahane, sir, and Dr. Mohan Rajan, sir, and Dr. Arun Sethi, sir, have contributed to the society, saved it either for the state or through the trust. But here I'll be talking about what I have to do with my small practice. In 2017, this was the state, and we moved to this larger facility in 2017. Retrospectively thinking, whether I did it right, I don't know. But what happened? Whatever happens in any kind of investment is this. The first 2 to 3 years, that is the time we fill in out-of-pocket investments to maintain that practice. And then from 3rd year, we pick up somewhere around 4th or 5th year for any big hospital to break even. I knew this and I kept some reserves. But then once we break even, then it becomes better. So I'll be talking about my practice where COVID struck us exactly here at the trough, when almost everything was exhausted and we had to look into it. Just like I told you, it was still a time when my business was improving, but we still needed money in terms of loans or whatever it was. Now, what did we do during the COVID? What happened during COVID crisis? During the lockdown, that is between March and August, because though the lockdown was lifted a little bit earlier, the trend was continuing till August. On an average, from 0 till around 12 or 13 OP, that's how the OPD had dropped. Surgeries were almost nil. It had just picked up in July and August. Collection was bare minimum, if you look at it. Post-lockdown, September to November, it was picking up, but there was high resistance, maximum of around 50% in surgeries and collections. The recovery period, December to March, particularly January to March, just like how Dr. Mahipal sir was telling, we almost hit more than 100%. And March was a very good month, so we thought we are going to come out of this. That was the scenario. But then all of us know what happened after that. If you look at the revenues, these are the true revenues of my hospital. These are the earnings from almost 5 lakhs average in that lockdown period, improved, and then we went ahead. But at the same time, the expenses also increased. Here, the expenses increased because of the loans that were brought into the picture. I'll show you what happened. And thereby, just when we broke even again, making the profit, the second wave has hit us. Keep calm. That's what I was always, I've been telling myself, everyone has been telling. When we look at an eye hospital, each one is interlinked. Sales, when they reduce, then you have to think about liquidity, which actually is final. Workforce is affected. Luckily for me, it was not that much. Supply chain, even that 1 or 2 patients coming in, he doesn't get what he wants. And all this, of course, employee safety, well-being, take care of people trying to cheat you. And all these, of course, governance and regulatory risk, all these lead to profitability concerns. What were the problems I faced? If you divide it into 3 clusters, definitely the demand, it was very less, patients were less, however, expenses were more. Liquidity concerns, I couldn't get the money from anywhere, even couldn't sell whatever I had. So there was issues there. And when you consider people, I was lucky enough, not much of a fraud, and my biggest strength was this employees. They stood by me except 1 or 2. But where did we face the problem? Governance and regulatory. Number 1, none of the promised loans were coming. And in place of that, there were a lot of regulatory things that were applied. Need not have to go into it. like we have been asked to change the CCTV, change certain things from the fire regulatory part, all these things. When we look at the third part, it was the business discontinuity that was creating trouble for us. Of course, there was a little bit of fraud. Luckily, we tried to look into it and then somehow sorted it out, not a major threat. Most important problem what we are facing was this supply chain disruptors, particularly in opticals and the pharmacy sector. Dr. Mahipal has spoke about this. So let's see what really happened. In the lockdown phase, post-lockdown recovery, this is something I'd shown. In the lockdown phase, there was a blanket moratorium. So the expenses went down drastically. We could still survive. Post-lockdown was when we started facing problems, when we had to dip into this personal savings plus pension down. The recovery stage, partially when we were returning things, the next wave hit us. So we would be prepared for that. March 21, the cycle resumes. This was actually a slide which I had presented in April, during April when the first AIO's webinar was conducted. I slightly modified it. The plan, whatever was put up, definitely we did relook at the business plan, stopped all the purchases, tried to sell a few redundant things that were available, but not much of a thing. In the interim, trained the staff so that they could multitask and stop all levels of marketing and deployed social media marketing. This is one thing me and a couple of my staff learned social media marketing, that we are certified social media marketeers now. And then the entire lockdown period, the money was coming only through this, the online consults. Yes, all these days we used to tell online consult is not good for ophthalmology. Yes, true, to a certain extent. The first consult, we cannot utilize the online consults. But follow-up consult, it's excellent. And at least to make the patient come to the hospital, the first visit is very good. Trying to get more funding, family and friends definitely helped me, but government and bank definitely let me down. Let's not go into the details. Yes, we did this, reduce the marketing expenses, reduce the fixed cost, reduce the stationaries. Some of it was outsourced. I'll show what they were. Inventories were completely brought down to near zero. Disposables, most of the things I was using was disposable. Went back to my older machines. Group practice is something I tried but could not stop. Now, this is one thing I want to specify. Luckily for me, most of my staff, except one or two, except probably 10% of my patients and their place, we could retain. And I'm really thankful to those staff and those patients. There were a lot of HR problems. All of us would have faced this. Staff were afraid. Most of them were very young. They left their state, come here, staying with us, and then working in our hospital. There was a threat of greater attrition of staff. Many of them wanted to go back. There was because they were also fearing a pay cut. Many of them had cut the pay. Even I had not given the complete pay in the first month of lockdown, which was later given to them. They couldn't travel between their place of staying. Though it's hardly 500 meters, but there were issues in travel. Working hours had to be extended because we had created 3 different shifts. So one person had to manage everything. And if they had left, I would have had a big problem getting a new staff. So what we did here, what I learned, merely sitting down and talking to them. Now, most of this staff are less than 26 years. Average would be around 24, 25 years only with me. Very few in the upper thing, except the doctors and the management staff. So sitting down and talking to them, telling the problem, showing them what it is, almost all of them stayed back with me except one. As regards contracting COVID, 3 of my staff got COVID, got them treated. All 3 were hospitalized, got them treated. Hospitalized in the sense, I mean, they're staying in an accommodation provided by us, but they are from out of the state. They got treated, home treatment, but still they stuck on with me even till date. Patient-related problems, this is one place where we get all sorts of patients. Genuine problems where the patient could not come here. If at all, if they come, they are always afraid. When staff is afraid, why not the patients? There was always a risk of cost escalation, thinking that we're going to pass on the cost to them, considering what happened in general hospitals. Less opticals. People were not even buying glasses, let alone surgery. Surgery was near zero. What did we do here? Let's be frank. I didn't drop charges, but neither did we increase the charges, nor we gave anything free. But wherever there was a genuine concern, believe me, a patient who had a trifocal IOL in one eye, hypermature cataract in the other eye, comes and says, is there a camp available? This was the real state to at least 30-40% of Indian population. Some of those patients, we did it for free, of course, with a caveat that they have to pay us later on. As regards the finances, yes, revenues dipped down. EMIs were always there. Salaries, initially there was a cut, but I returned all those salaries by March. There was no rental, luckily, own place, but then rest of the things had to be taken care of. But what was important, we couldn't raise this tariff. That's something all of us have to look into as a society. Patients not coming in from out of the area. There were times when patients used to come in from adjacent cities also, but that reduced. Social distancing has increased the time. Social distancing, all other things have increased the time, and in additional infrastructure costs have increased thanks to all the UV lights, our PPE kits, all these things. This has still not been addressed. I thought we were out of danger in February, March, but then with the second wave, still we need some support for this. Yeah, I'm almost. Opticals we had outsourced, so nothing much, completely given it off to someone else. And these were the changes we made, reduced our budget, reduced the inventory. There were no cash to protect, but whatever we got it. Most important thing, I changed my chartered accountant. He showed me a lot of things where we could have saved. Still applying for this restructure of loans or moratorium, and that is yet to come. Now, we were thinking, hopefully, that it will be a V recovery. Later on, thought it might be U recovery when we could have passed out. Now it's going to be W or some multiple Arabic letters. That's going to happen. I just clipped this slide from Dr. Mahipal's slide, where we are as individual practitioners. People having very small practices, no issues. Someone was trying to get into the next level. We are still here. Went to return and then came back. 3 more steps to achieve that break-even. Now, after lockdown or after this pandemic, what to do? Can we increase the consults? It's a dicey situation. I don't think that's possible. Online consults is very good. Automatize. Now, this is something that is going to bring down the cost of the hospital. Initial cost might be high. Automatized by a good software. And of course, look into these financial burdens that we might be. Impossible is nothing, definitely. Thank you once again for providing me this opportunity.
Must say a very well detailed, well organized presentation on financials. But you know, the first thing that comes to my mind is that yesterday in our session in AIOC, Dr. Vashisht actually gave a list of a new survey they've done called the Atlas of Eye in India, in which they have mapped a lot of centers, clinics, tertiary centers, hospitals, all the panel. You know, you have the whole gamut. What it shows is that 2 things. One is that there is a dearth of ophthalmology in the eastern and northeastern part of the country. There's an excess of ophthalmology in northern, southern, and western part of the country. Now, this itself tells you that what is happening in the field of ophthalmology today. Secondly, there is no system of sharing of equipment. Can you imagine today a single practitioner is also forced to buy an OCT, a LASIK laser, a femto laser. Nowhere have I seen, my neighbor is one of the most expensive lawyers in the country. He's also a member of the parliament. He charges 18 lakhs per appearance in the court. He has no technology except a computer and a laptop. All the money is profit. So there is something wrong in the business plan of ophthalmology of today. Because I cannot visualize a single practitioner being able to recover the investments at any cost unless he does only ophthalmology from morning to night. Now this brings us to the next level of thinking, that group practice may still be far away, but sharing of equipment has to be done, because it is a national disaster to have multiple LASIKs lying idle, to have multiple OCTs lying idle. Every medical college has huge grants to buy equipment. All India Institute alone, RP Center has a grant of 150 crores to buy equipment in a year. New equipment is bought, old is condemned. There is no recycling, nothing. If the government was to put its act together, make it easy for private practitioners to access equipment in these places, a lot of single practitioners would then start flourishing.
Absolutely.
Technology is killing practices, not building practices. It is also taking ophthalmology out of the reach of the common man. And this thought process is just not there in ophthalmic practitioners. How to make, using the airline fares are coming down. The cost of technology is coming down, but the cost of healthcare is going up. So maybe it's time for ophthalmologists to consider whether single specialty hospitals should be allowed or they should all become multi-specialty so that if one specialty goes down, somebody else can compensate them. Dr. Lahane and Dr. Mohan Rajan, what is your opinion?
Yes, sir. Lavanya, would you like to go first, sir? I don't mind. I fully agree with you, Arun. I think it's very important to have a group practice concept, at least sharing the equipment, optimizing the equipment. For example, your OR is, you are using the OR only for 2 to 3 hours a day. The rest of the about 8 or 10 hours is absolutely going waste. Similarly, your femto, your LASIK, or what, so much of investment is there, and you're not going to get a return on investment. And what I want to add, Ilan Kumar's speech was really fantastic. His talk was really covering everything. Is to all of us should think of creating what is called a disaster fund, okay? Which I wanted to do it about 2-3 years back, but I completely I overlooked that. And by the time the COVID came and hit us, the disaster fund is very important. Every month, whatever profit you have, X amount of profit, whether it's a 5% or 10%, you have to put it in a separate account and don't touch it. It's like a fixed deposit. Don't touch it. Yeah. So this is a disaster fund is something which all of us have to look at. And of course, the group practice concept, which is very, very necessary, because otherwise you cannot overcome a pandemic like this. Lagane sir, you're...
So you're muted.
You to unmute, sir.
Yes, yes. Yes, you are correct. What Arun Shetty sir and what Mohan saying was very true. Group practice. And Ilan Kumaran, I think you have covered each and every aspect of the single practice. I think that is what we should do it. And now this is the now we'll have to go for the even what Mohan was saying. Some money we'll have to keep for the disaster. Now
Yes.
this disaster we have not seen in last 1 century, but it has came. Okay, now we'll go to the next speaker. That is nothing. It means no other than the Sabaya Sachin Gupta. He is from Mumbai, practicing Borivali, and he is an excellent retina surgeon. And he is more interested in the research. He is going to speak to us on the psychological, you can say, impact of the COVID-19 on the healthcare workers. Sabaya Sachin, go ahead.
Thank you, sir. Very good evening to everyone, and very happy to be part of this August gathering of speakers, and amazed to see the amount of work that so many of you have already done. So I'll just start sharing my screen. So I have been part of a couple of psychiatry teams who have evaluated some kind of data on psychological impact of COVID-19 on physicians, and I thought I'll bring some of my experiences as well as what literature has evolved and where we are today. So, so if you want to ask ourselves, do you think COVID-19 has caused mental health issues? And I think the answer is a no-brainer, right? So it has affected every individual on this planet, irrespective of what their profession is. But somehow I think healthcare professionals are probably affected by this more than others. So what I'll show you is some percentages as to how many of us might have been affected by this, and why that may be so. And lastly, what we can do to mitigate these problems. So if you do a quick literature review, which I've done about 2 hours back, and if you see the search words, it's on COVID-19 psychology and physicians or doctors, you will get more than 1 million hits on PubMed. So that's a huge number. So imagine how much people have actually felt this and done work on this to bring it out in such large numbers. So physicians involved in COVID-19, I think it's important to classify them and that not everyone would have been affected in the same way. So physicians, those who are in the firing line or on the front lines, those are the ones who are actually providing intensive care to patients and actually intubating patients and giving them CPR and others. So they are basically intensivists, chest physicians, ICU nurses. And so intensivist is more of an umbrella term. So there are many people under that. So anesthesiologists, people who are MD physicians and others. So they might have been affected slightly more, and I'll show you some numbers to actually show you that that really was the case. Then non-intensive care, there are so many others, again, like physicians, radiologists, cardiologists, pediatricians, endocrinologists, and of course, large nursing staff who are actually present but not actually giving ICU care to these patients. Then there are so many who are involved in indirect care because COVID might be causing some symptoms in other parts of the body, such as ENT, ophthalmology, psychiatry, of course, and nurses. And then there are some who are not at all involved in care, and some of us might have also fallen into that. And so, and all of this also affects resident training. Every resident in every specialty might have been affected, or actually is affected, like Dr. Rajesh Sinha has told us, and Lahane sir has also told us. So there's something that I will not cover, but we'll quickly look at what is the scenario of these physicians in terms of their psychological health. So, the real issues which emerge when you actually look at literature and work with some teams like these are anxiety, sleep disturbances, depression, perceived stress, stigma, and others. And this is across the spectrum. So how did frontline workers do? When you ask them about these, 65% actually said that they are depressed. And so that's, I think, a very large number, every 2 in 3. So if you know an anesthesiologist or somebody who's involved in frontline care, there's a high likelihood that they are probably depressed, though they may not show it. And then 45% had severe anxiety and stress. That's again a very large number. And the main causes really were lack of PPE kits, fear of contracting the virus. They're worried about transmitting disease to their families, and younger physicians were more affected than the more experienced ones. So, this is essentially the overall scenario for frontline workers. And also, 54% said that they were burnt out. And these surveys were done about 3 months after the onset of COVID. I'm sure these numbers have dramatically increased by now. And then 96%, or almost all of them, said that they had sleep disorders. They were not able to sleep. Even if you give them shift duties, they're still not able to sleep. And so, this is really difficult to sort of get over. But the scenario is such for frontline workers. For non-intensive care workers who are not on the front line, again, these numbers are still high. So 50% have some amount of depression and anxiety, and 7.3% had severe anxiety, and some of these were also suicidal. So these numbers, if you see, are 65% for the intensive care workers who are depressed, and this is about 50%, so slightly lower, but still they are actually suffering. So 1 in 2 is actually having some of these symptoms. And again, the common causes were lack of PPE care, fear of contracting the virus. They're worried about transmitting to their family, and younger physicians and women were more affected. And why I'm bringing these reasons up here is because we'll have to deal with them and look at mitigating strategies to overcome these. Then a survey amongst physicians and general mood and quality of life amongst physicians showed that about 30% are continuously in a negative mood, 40% are in a low mood, but 10% are still in excellent mood, and 20% are still in good mood. So it's possible that people can somehow develop strategies to even subconsciously we might develop strategies to not to come out of depression. When people were asked about satisfaction at workplace and their work experiences, a lot of people actually said that they were not very satisfied in the way they were working. And a lot of them actually cited poor working conditions, but then they did not blame any authorities for these, because most people understood that the unprecedented nature of the situation. However, the fact is that there were poor working conditions for a lot of these physicians who were taking these surveys. And this was across the spectrum, so there were from trainee doctors, from radiologists, from neurosurgeons, from dermatologists, from spine surgeons, across the spectrum. And this is not just limited to India, but globally, almost all were, having these kind of issues. One paper that I came up from Singapore dealt with psychological impact of COVID-19 on healthcare workers in Singapore, and I found that these numbers were dramatically low. Only 15% had anxiety, 9% had depression, and 6% was stressed. So most of the physicians seem to be very happy doing their jobs in Singapore. And when you actually try and read the paper, you only get one answer, and that was training. And these people were given training as to how to deal with these even before it started. So that's probably something that policymakers should think about, is preparing the workforce for what is coming. This is the actual scenario in ophthalmologists. So this is a paper which is published in the Indian Journal of Ophthalmology about a year back on psychological impact of COVID-19 in ophthalmology in training and also practicing ophthalmologists. So more than 2,000 ophthalmologists responded to this survey, and the mean age was 42. So it's relatively younger ophthalmologists. 57% were men, and 53% felt that COVID-19 would impact their training, and 37% had difficulty in meeting their living expenses. So a third of us actually had problems even with living expenses. So that was something which was very surprising. But then the ground scenario was such. And the psychological impact this paper brought out was that 33% are depressed, and that 4.3% had severe anxiety and stress. So the overall depression compared to frontline workers is definitely lower, right? So it's only one in three who's having depression, while frontline workers it's 2 in 3. So that's almost double. And also the severity, anxiety and severe anxiety and stress levels are relatively lower in ophthalmologists. And though in this subgroup it was much higher in young ophthalmologists, that is under 40, women and those not earning well at baseline. So it's more like trainees or people who have just started out maybe in their practice. But then this was still relatively high. I think from a subspecialty perspective, 1 in 3 ophthalmologists being depressed is still quite high. So just giving you that perspective that most frontline workers were depressed, anxious, having sleep deprivation and other problems. Non-frontline workers, it's about 50%. By an ophthalmologist, it's about 33%. And so if you want to really choose which basket you want to be in, I would definitely choose being an ophthalmologist any day. And I think sort of the nature of our work and the specialty meant that we were not really equipped to train people in the front line. And somehow ophthalmologists have dealt with this probably slightly better in terms of their anxiety and depression numbers. So how to deal with this? What are the mitigation strategies? So when you look at this paper from Singapore and some other strategies that the NHS and others have come up with, and the first thing they talk about is something called psychological first aid. And that was again a new concept for me, so I had to do a lot of digging. But it really simple is make a psychologist available for people to call anytime they it's like a hotline where there is a trained psychologist on the other side of the line. And then have doctors, friends and family continuously speak to these these individuals about whatever they need. So call me anytime you want. So that was sort of a punchline that these studies said. Then self-care strategies such as rest, work breaks, sleep, shift work, fatigue management, health, lifestyle behavior. So these are all concepts on their own, and we could actually talk about these for hours together, but these are something that people can be made aware of. And managing emotion, I say moral injury, coping, guilt, grief, fear, anxiety, depression, preventing burnout and psychological trauma. So these are some of the things that we can use to mitigate strategies. And this is a paper which talked about public health sort of angle and how and ways to deal with this. And they said that what can be done is that 30% of the onus lies with policymakers, where they provide a safe working environment for people to work. Simple things like providing PPE kits and things like that can actually be dealt with by policymakers. 50% of the onus is on providing more assistance to physicians on the front line, and as well as those who are suffering from these mental health conditions. And then 20% is training to handle that. So just a minute. I think we need to break barriers. We need to hang in there. We can only things can only get better, and we need to find new ways. We need to innovate, think out of the box. And the 5 R's that Mahipal sir said also comes up when I was looking at this. So we need to resolve, have resilience, return with a bang, reimagine, and reform ourselves. There are a couple of books that people might want to read that will really help you. One is on Think Smart and Work Smart. That there are a lot of strategies which we have been actually discussing through this session, and also another book on 21 lessons from the 21st century, which can actually help us prepare for things to come. So I think the overall summary is that there is a problem of depression and anxiety, which is high. It's much higher. Frontline workers are suffering more. Non-frontline workers are suffering slightly lower. And ophthalmologists, about a third of us are still suffering. But then there are solutions and mitigation strategies which we can utilize to overcome this. Thank you very much.
Lovely talk, Sebayachi. Lovely talk. Very beautifully covered.
An incident of a doctor who committed suicide in Delhi with the stress of COVID.
Yeah.
Really sad situation.
It's a very bad situation. Sabaj, I just wanted to ask you, have you found any correlation between the what do you call the psychological aspect, that is the anxiety, depression, and the stress, and the heart attacks?
So I don't think we have had too much of study on how these translate into physical disorders as of now. But these definitely have been studied pre-COVID, and it is all true that people who have more anxiety and depression, people who are suicidal also have more of these cardiologic abnormalities. So this was all, of course, known and well studied pre-COVID. I'm sure it's going to happen even now. Though we haven't really studied, we haven't studied it per se with under COVID, but I think there are many other important aspects to study. But I'm sure that is true. What you say is true. The trends are definitely there.
Definitely there.
More than that is the financial aspect. People are going to be very bad financially hit, except those in government jobs. You'll find doctors in practice, industrialists, businessmen, they're all getting very badly hit. They're not sure whether they can revive their businesses. I walk every morning with a very rich businessman, and he is selling all his assets because he doesn't have money to pay his debts. Things are tough economically. That also causes stress.
I'm also a little shocked at the figures Sabyachi was telling, that 37% are finding it to even what do you call
Basic livelihood, yes.
penniless, finding it for the livelihood. The livelihood itself is a major problem for them, and I'm sure during the second wave it's going to be even worse.
Right.
It's very interesting. A colleague of mine's son got MS ophthalmology in D.Y. Patil in Bombay, but he never took the seat because he was scared that his son will be put on COVID duty. He would not make it. So he dropped the post-graduation for 2 years.
All the postgraduates are put on COVID duty. Whether you are in Bombay or in Chennai or Delhi, all the postgraduates are in COVID duty. They have to do it. My daughter was in COVID duty in D.Y. Patil in Pune, and she contracted COVID after 2 weeks of COVID duty. It's a part and parcel of the whole thing. I think we have to.
I mean, the parents get scared, you see.
We don't do it, then who else will do it? You tell me.
Dr. Lahane, one thing I'd like to request you is that we should create a national grid of doctors. I was very touched reading in America, doctors were flying from Los Angeles to New York when New York was suffering in the first wave to do voluntary work. They were getting free tickets. They used to take the night flight to New York, put in 2 weeks of duty, and help out their colleagues, and then fly back after 2 weeks of this quarantine back to Los Angeles. Now, that kind of a drive should be there in India. 80% of the doctors are outside the COVID duty. The ones who are in the ICU are getting battered because they have to keep doing the same thing again and again. There should be a national grid by which we can get doctors who are willing to do volunteer work. I even suggested that to Harsh Vardhan, that later on they started asking doctors who want to volunteer, that there would be doctors who are retired intensivists and others who could be used for this kind of a thing, who could bring down the pressure on the youngsters, who could be used for teleconsultation. So many things to be done in the villages, but we are not prepared. What is the National Rural Health Mission or whatever we call it? What are they doing in disaster management? These are things they should be looking at.
Yeah.
True. Yes. You are Chetty sir, you are very correct. But in national grid is very important. And in Mumbai, what we did, we asked the private practitioners from Mumbai that they should join hands with us. And near about 4,600 doctors from Mumbai who was a practitioners, physicians, they joined with us. But there, we restricted them below age of the 45. All young doctors, they joined with us. And they worked for the 14 days. We paid them, but they worked for the 14 days. And that was, I think, a very good thing that practitioners came in. Otherwise, so beds there that time, we were only 23,000 beds. And then we made 1 lakh bed in Mumbai. And for that, the doctors are required. That maybe you can say the allopathy, homeopathy, and all practitioners, they joined hands. Also the nurses, 11,000 nurses, they came. And I think we could manage Maharashtra. And it is
right, sir. Because
I think we must have a national grid. We'll do it definitely.
Absolutely.
So one of the things very touching was an ophthalmologist of Odisha converted his hospital ward into a COVID ward and accepted patients for COVID free of cost managed their oxygen levels and treated them with steroids, because in his district, he said there was no facility to treat COVID. And only when they became serious did he shift them to the district hospital. So he treated about 180 COVID patients in an eye hospital and learned everything online, how to manage. Now, that is the beauty of ophthalmology.
Brilliant, brilliant, brilliant. I think, is Lalit Verma here?
I think Lalit is not still. So,
Okay, then we'll close the session, sir.
yes.
With all due respect, can we wind up now if we don't have our next speaker over here?
Okay.
Yeah. Thank you so much, sir. Thank you, everyone, for giving me. I was so attentive over here. I mean, that was something I was actually enjoying. So thank you so much for this wonderful session, and have a great night. Thank you so much, everyone. Thank you to all the chairpersons.
Thank you, doctors from scientific team also. Wonderful session.
Thank
We'll
you.
meet tomorrow. Thank you.
Thank you, everyone. Have a good night.
Everyone, have a good night.
Thank you, sir.
Good night.